How do you manage specific pancreatic cyst types? Managing pancreatic cysts can be complex and varies based on the type of cyst, its size, symptoms, and individual patient factors. The main types of pancreatic cysts include pseudocysts, serous cystadenomas, mucinous cystic neoplasms, and intraductal papillary mucinous neoplasms. Each type requires a tailored approach to balance the risks of cancer progression against the risks of surgery. Let's start with pseudocysts. These usually develop after pancreatitis and are generally benign. If a pseudocyst is asymptomatic and stable, doctors may choose to monitor it without any intervention. However, if it causes symptoms, grows larger, or has complications, drainage might be necessary. This is often done endoscopically, using an ultrasound-guided needle. In some cases, surgery may be needed for persistent issues. It's important to note that if pancreatitis continues, there is a chance of recurrence. Next, we have serous cystadenomas. These are typically benign and have very low chances of becoming cancerous. Small, asymptomatic serous cystadenomas can be monitored without treatment. However, if a cyst is larger than 4 centimeters, grows quickly, or causes pain, surgery may be recommended. The surgical approach usually involves removing the affected part of the pancreas, depending on where the cyst is located. Mucinous cystic neoplasms are a different story. They carry a higher risk of becoming cancerous. Because of this, surgical removal is generally advised, especially for cysts that show suspicious features or in younger patients. The type of surgery will depend on where the cyst is located. For example, if it's in the tail of the pancreas, a distal pancreatectomy might be performed. After surgery, regular follow-up is essential due to the risk of recurrence. Intraductal papillary mucinous neoplasms, or IPMs, can be categorized into main duct, branch duct, or mixed types. Main duct IPMs have the highest risk of malignancy. Management depends on various factors, including cyst size and the presence of concerning features. If high-risk features are present, such as obstructive jaundice or certain cytology results, surgical resection is usually recommended. For low-risk branch duct IPMs without concerning features, monitoring with periodic imaging is often sufficient. Lastly, there are solid pseudopapillary tumors, which are rare but can also have malignant potential. Surgical excision is typically required when these tumors are diagnosed. For cysts that are not immediately removed, active surveillance is key. This includes regular imaging, such as magnetic resonance imaging or computed tomography, and possibly endoscopic ultrasound with fine needle aspiration. The frequency of monitoring can vary depending on the type of cyst and its risk factors. Surgical options will depend on the cyst's location and the patient's overall health. Procedures may include the Whipple procedure for lesions in the head of the pancreas or distal pancreatectomy for lesions in the tail. In summary, asymptomatic benign cysts often requiring no treatment but should be monitored regularly. Cysts with high-risk features or symptoms usually need surgical evaluation. It's crucial to consider individual patient factors, including age and overall health, when making management decisions. A multidisciplinary approach involving gastroenterologists, radiologists, and surgeons is essential for optimal care. Always consult healthcare professionals for personalized medical advice tailored to your specific situation.